Hi guys, welcome to the meningitis part 2. I'll be first talking about the workup of this particular case. Well, the first investigation to be done, as explained to you earlier, would be a blood culture, and I would be drawing a blood sample and then giving empirical antibiotics to the patient. We are not going to straight away do a lumbar puncture because the patient would be having a raised ICP. So I would first like to give mannitol to decrease the pressure to normal values, failing which there's a distinct possibility that there could be a transtentorial herniation and the patient can actually expire. So to pick up the evidence of raised intracranial pressure, I'm going to do a CT head in the patient. And if I do not have facility for that, or let me say the CT scanner is busy because there were multiple trauma cases that came simultaneously, I can do a fundus examination and then I'll give mannitol and perform a lumbar puncture. Now the question to you guys is that can you tell me the name of this lumbar puncture needle? Well, in English, obviously, we're going to call it a lumbar puncture needle, but what's the technical name of it? You can see that the lumbar puncture needle per se will be having a plastic hub at the back that would tell you that your needle has reached the right place once you poke the patient at L3, L4. The cutting edge of the needle can be fairly sharp. This would be a double-edged blade present that will cut through the various layers that I'll discuss with you. But the question is still open, guys. Can you tell me the name of this needle? And I would also like you to compare the current lumbar puncture needle that I have sketched before you versus the one which is relatively atraumatic. If you compare the two, I want to highlight that in the second one, the tip is relatively less pointed and well, the hole which would help in getting the CSF per se would be present relatively laterally rather than bang on the tip per se. Well, I think you would have guessed answers by this point of time. I did give you sufficient time. The first needle, which I can say the word traumatic lumbar puncture needle, is Quincke's needle. Initially, when you are practicing for first time, you should obviously be using a Quincke's needle, but once you're done with it, you would then be using Sprotte. Sprotte is a atraumatic needle per se, and the point that you need to understand is that if you are gonna punch a hole in the dura mater while doing a lumbar puncture with help of Quincke's needle, then there would be a persistent CSF leakage. You see, I said the needle has a double-edged bevel. So when the needle will go inside the dura mater, it's going to separate the fibers. When you're going to withdraw the needle, it's going to evert the edges of the dura mater and there's going to be continuous CSF leakage resulting in headache. You are very well aware of the complication of lumbar puncture. That's going to be headache. So I should be using the thinnest possible needle, and at the same time I should avoid separating the fibers of the dura mater. So I'll tell you the technique per se. How are you gonna introduce the needle? The bevel should be up, bevel should be down. How are you gonna progress subsequently? But the message is that wherever possible we should try and use Sprottes needle. This would be minimizing the trauma to the fibers of the dura mater, and therefore the incidence of headache will definitely be significantly reduced. Now, if they ask you what is the preferred site for performing a lumbar puncture, then you can answer it as L3, L4, and you can do it either with the patient in sitting position or the patient can be in lateral decubitus position. I am preferring a lateral decubitus position because patient is sick. So if I'm going to make him sit up, there's a possibility that he can fall also. So to minimize the possibility, it's better to actually have an attendant who's going to help you in helping the patient curl up in a fetal position with the knees going up to the chest, and then you can access the back of the patient while he is in lateral decubitus position. Now comes an important question. When you are introducing the needle per se, should the bevel be up? Like if you are using Quincke, should the bevel be up? Should the bevel be down? Should the bevel be perpendicular? Well, the needle is introduced. We are talking about Quincke's at the moment. The needle is introduced, bevel up. What are the layers that would be cut will also be told to you. Once you introduce the needle, you go through the skin, then the subcutaneous tissue. Now you need to progress the needle further. The point is, would you like to go straight? Would you like to go slightly cephalad, or would you like to go slightly caudal? The question is still open. Introduction is bevel up. Now we are going to talk about the progression of the needle via the subcutaneous tissue into the supraspinous ligament, interspinous ligament onwards. It has to breach through the various ligaments before it reaches the dura mater per se. So the point is the progression of the needle will be slightly cephalad. Remember my words. The textbook says the word aim for umbilicus of the patient. So imagine you standing behind the back of the patient. You are poking the patient at L3, L4. Bevel is up, needle goes inside, but then it's not going to go directly straight up. It's going to go a slightly 15-degree cephalad. So aim for the umbilicus of the patient is the objective in this case. And while you are going to do this, you can definitely pop the dura mater. Let's also have a look at what are the layers that are pierced. Though I'm very sure you are aware of that from your anatomy knowledge, let's just practice it. It's going to be the skin, then it's going to be the subcutaneous tissue, then you have a ligament, right? That's going to be breached. So I would suggest you that when you're doing this procedure, you should rather go relatively slow. There is no rush, because I want you to feel the layers. I want you to feel the resistance, because when you go through these ligaments, you will definitely be able to feel the crunch when you go through these layers. So it's the supraspinous ligament that is gonna be breached at the movement. Then you're gonna encounter another resistance. That's gonna be the interspinous ligament. Then you're gonna reach ligamentum flavum. Now I wanna tell you that in the exam what he did was that in place of ligamentum flavum, he mentioned the word ligamentum denticulatum, right? You're aware from anatomy, this is not ligament denticulatum, this is ligamentum flavum. And now you're gonna reach the dura mater per se, and behind the dura mater will obviously be the CSF that you're actually looking for. The objective is to minimize the trauma to the dura mater. You're aware of the fact that lumbar puncture is absolutely contraindicated in a scenario of raised ICP. That is why I said when the patient comes initially, stabilize the patient, give mannitol, get the intracranial pressure back to normal, and then perform the procedure. Never try to do a procedure in a person who is on warfarin, because you can understand that if a person is having warfarin toxicity, or let me say if his coagulogram is deranged, then he could definitely bleed. Local site infection is obviously a very common thing that you can understand, especially in unhygienic situations, especially if it's a poor patient in a hot Indian summer when it's going to be sweaty and sticky. That's when local site infections like pyoderma could be there. There is no need for any heroics, especially when it comes to kyphoscoliosis. You see, if somebody is having a deformity in the spine, and you're trying to navigate across it, you might hit the bone, you might hit a nerve root, which really does not make sense. So I said there is no need to play heroics per se. And for the next one, I don't want you to note down, just listen to what I'm saying. You see, polio has been eradicated from India. It's still there in Pakistan, Afghanistan. Tomorrow these countries decide to contaminate our water supplies, then well, we can have polio coming back. Anyway, coming out of it, I want to tell you that when I was a student at your age, I saw a lot of cases of paralytic polio. We never used to do any invasive investigation per se in a case of polio, because studies have shown that when you're gonna try and give, forget about a lumbar puncture, if you are gonna even give intramuscular injections in a case of polio, the spread of the virus tends to increase. I said all invasive procedures are not to be done in a case of paralytic poliomyelitis. Studies have shown that when you perform any kind of invasive procedure, there is a distinct possibility that the progression of the virus per se will increase. So the last point is obviously just for your routine knowledge, but obviously the standard ones, especially bleeding diathesis, because they give a question of a hypertensive guy who's ending up with development of atrial fibrillation. He's on warfarin, his coagulogram was deranged. You see, he linked up cardio with neurology. He said this chap is a known case of atrial fibrillation, and then he started having fever, he was having nuchal rigidity, he was having a headache present. So lumbar puncture in those circumstances can't be done because the coagulogram of this guy is deranged. We will like to get coagulogram back to normal, or at least in respectable values, and then we can definitely safely perform lumbar puncture in the patient. Now we'll come to a practical aspect here. Let me say this line represents the dura mater that is to be popped, and then you can obtain the CSF. And you are doing the lumbar puncture. The objective is that you cut through the various layers that I just explained to you, so that the cutting edge of the needle just breaches the dura mater and you would have the CSF of the patient. However, there's a distinct possibility that the young doctor who's doing this procedure was over enthusiastic, and what he did was that he pushed the cutting edge of the needle too deep inside. What I'm trying to say is, if you punch a hole in the dura mater, the cutting edge of the needle is very sharp. So when you go inside, you're going to cause trauma. When you come outside, you're going to cause trauma. And now I have highlighted in this diagram that unfortunately, in our case, there is slight eversion of the edges of the dura mater, because of which there might be a continuous leakage of cerebrospinal fluid through this area, and that will explain post-lumbar puncture headache developing in the patient. Well, this is bound to happen. So since we know that post-lumbar puncture headache is definitely going to occur because of the leakage of the CSF from the breach that you have caused in the dura mater, what would you advise the patient? You would advise a strict bed rest. You will say, don't go to the bathroom, don't walk to the bathroom. We'll provide you a bedpan, if required a condom catheter. So try to urinate in the bed itself. Just take good bed rest for a few hours, maybe 8 to 12, and you'll be fine. If required, you can obviously use painkillers in the patient. Like if required, you can maybe give COX-1 inhibitor like diclofenac IM if the pain is not tolerated, because everybody has a different pain tolerance, no? Now you have done this activity, but still there is gonna be headache. What are you gonna do in this case? You can then use the preferred drug, that would be IV caffeine. So you will notice lots of time we advise a hot cup of tea or coffee to be given to a patient post lumbar puncture after 8 to 10 hours if there's a persistent headache. And well, tea and coffee would also be having caffeine. Studies have shown that it will work, but you have tried everything. You have used COX-1 inhibitors, you have used caffeine, you have used even opioids in the patient. You see, codeine have written a little unfairly because you're aware that codeine can contribute to constipation, and the more he will strain, more will be the leakage of CSF, and that can definitely cause problems for the patient. In those circumstances, let me say you have done whatever best is possible. You have given opioids to the patient as well, but still the headache is present. It's been 24 hours, maybe even more. In those circumstances, let's now look at what are you going to do and what are you going to tell the patient for a case of persistent lumbar puncture headache in spite of the medications that I have talked about. Well, you would first tell the patient, inform him, sir, there is a hole in the dura mater. He's not going to be happy about it. He'll say, sir, I came to you for a cure and you're telling me that there's a hole in the dura mater. I'll tell him, yes, sir, it was actually caused by the needle and I can fix it by, I gave a pause here because I'm going to tell the patient, I'm going to be silent for a few seconds, tell the patient that, sir, I need your permission to do the procedure again. He says, are you serious, man? You punched a hole in my dura mater. Now you're telling me you're going to punch a hole again. I'll say, no, sir. Right? Patient is educated. I'll say, sir, what I'll do in you will be the procedure once again. I'll once again be sending in the lumbar puncture needle. And this time I'm going to go as slow as possible. He's going to ask you, last time you did not go slow. No, I went slow, sir. I'm going to go slow this time also. But I am going to now ensure that the cutting edge of my needle is just before the dura mater. You see, I'm going to breach all the layers, the supraspinous, interspinous ligamentum flavum. Then the needle advancement has to be relatively stopped because now I'm pretty close. I'm not saying that I'm going to hit the exact spot where I poked him last time, but my needle is now very, very close to actually where I had breached the dura. Once the needle is placed at this position, I am going to ask my technician or my fellow doctor colleague to do a venipuncture of the patient. My doctor colleague will maybe from the dorsum of the hand of the patient, cubital fossa, patient is lying on one side, maybe take a blood sample of 10 ml amount. My doctor colleague has now handed me over a syringe which is actually containing patient's own blood. I'm going to attach this syringe which is containing patient's own blood to this lumbar puncture needle, and I'm going to inject patient's own blood via this lumbar puncture needle into the spot where there was a breach in the dura mater. Well, when I inject this blood, you obviously have to ensure that there has to be very good coordination with your technician, because if the blood clots in the syringe itself, the procedure is a waste. If the blood clots inside the lumen of the needle, it's a waste. So I will inject this blood, and by that time the blood will obviously begin to clot. This blood will basically seal the tear or the breach in the dura mater of the patient. So my objective is that in a case who's having a persistent lumbar puncture headache, I can definitely go in for what is called as low volume blood patch. In fact, this was itself a question. Low volume blood patch would be useful for management of, your answer would be a persistent lumbar puncture headache. The sequence is like this: bed rest, painkillers if required. If they persist, use caffeine, then go in for codeine if required. I mean, opioids, whichever you have access at the moment, and codeine is easily available basically. Then would be low volume blood patch as a last resort that you can be using it. Also, a issue comes up is how much CSF can be removed. So for diagnostic purposes, it's about 20 ml, though for therapeutic purposes, it can be 30 ml as well. Let me explain this. Though I have explained this concept even in my previous meningitis part 1, let me reiterate it. How much CSF can be removed in single sitting? 20 to 30 ml. You see, normally for diagnostic purposes, you don't need more than 20 ml. I mean, you have to send it for culture and separate bottle, gram staining, then for CSF biochemistry, or maybe even a PCR. So not more than 20 ml would be required. But sometimes even for therapeutic purposes, you might be doing a lumbar puncture. Which condition do you do a lumbar puncture for therapeutic relief is a condition called as normal pressure hydrocephalus. This condition is characterized by increased CSF production at night which results in cortical atrophy, because if the ventricular system will dilate from inside, it's going to cause cortical atrophy. It's going to press the gray matter against the calvarium. There is also going to be ataxia. Why? Because the cerebellum would be pressed. You see, due to gravity, pressure will go down, cerebellum is impacted, and because of the pressure on the frontal lobe, they can even be incontinence. The most important problem in patients on normal pressure hydrocephalus is the ataxia component. So to neutralize and handle this ataxia component, what I basically want to do is that I can remove 30 ml CSF. Once I remove the CSF, I will notice that there is an improvement in the gait of the person, which is technically called as Fisher test. We are all aware of Miller-Fisher syndrome. That's a variant Guillain-Barré syndrome, but Fisher test is done therapeutically for management of NPH. Now, this is obviously for your routine knowledge, but I explained why that range, why that range of approximately 10 ml is present. If they simply ask you for therapeutic purposes, how much ml of CSF can be removed? 20 ml. Well, because the rate of production is also 20 ml. No? Let's have a look at some baseline data, which I think I have already highlighted, but let's ensure that you remember it. You see, the point is, if they ask you what is the rate of CSF reabsorption, then the rate of reabsorption will be equal to the rate of CSF production, because only then the pressure will remain normal. Now, please remember the rate of CSF production as well as the rate of CSF reabsorption, both of them, right, is going to be approximately 20 ml per hour. The total amount of CSF that would be present is approximately 150 ml. We can attach a manometer and we can also check for the opening pressure, because opening pressure is elevated if there is an infective state in the patient. Well, here I'm going to talk about a test also. The normal opening pressure would be 10 to 20 millimeters of mercury, 50 to 180 millimeters of water. Now there is a maneuver which is nowadays not recommended, but still because of historical purposes, I would just like to mention regarding it, that is called as quick and steady maneuver. Well, let us see what are we going to do in this case. You're performing a lumbar puncture in the patient, and at the moment, let me say I am sitting on a stool which is behind the back of the patient, and I'm the one who's performing the lumbar puncture. Now I'll ask my doctor colleague to actually press on the bilateral jugular vein of the patient. You see, jugular veins are going to be connected to the cerebral venous sinuses, and the cerebral venous sinuses are ultimately connected to the ventricular system in the brain. So when you press on the bilateral jugular veins of the patient, then you are impeding actually the normal flow, because you see the CSF is produced from the choroid plexus. It then is going to migrate to the basal cisterns. It's going to be reabsorbed in the subarachnoid space. It's going to go back to the blood. I mean, CSF is produced from blood, goes back into the blood. If you occlude the veins per se, it definitely contributes to rise of the opening pressure values. You will notice that if you attach a manometer in a person while doing lumbar puncture, the column will oscillate with respiration also, and at the same time even is connected to the venous system. So if you occlude the venous system, the pressure on the venous system will actually result in a rise in the column of the JVP. I'll just jot this data down. Cook and set maneuver is of historical importance. A doctor colleague of yours is putting pressure on the bilateral jugular vein. I'm talking about the intrajugular vein in this case, which is going to be related to the cerebral venous sinuses. So bilateral pressure on the internal jugular vein in normal person causes rise of CSF column. You will notice a appreciable movement. One, you will be noticing obviously movement with respiration. The second thing that you will notice is the appreciable rise of the column. But if there is a failure to rise, that means that there is going to be some kind of a blockage somewhere, because the pressure of the venous system is not getting communicated to the CSF circuit. So do remember, failure to rise is a feature that is encountered in patients with like lumbar canal stenosis. And this test per se, I mean, you need to remember, is only for theory-based questions. Cook and Staten test basically tells you that there's definitely a problem. There could be a lumbar canal stenosis also occurring in the patient. The pressure would definitely not be transmitted in this scenario. Now, these are some baseline informations that you should be familiar, because lots of time procedural issues with respect to meningitis have been asked. And now I'll describe to you what is going to be the actual picture in the CSF. We are going to talk about cells and the sugar and the protein. So I'll be drawing a table here before you, and I would suggest you to actually draw this table with me, so that you can remember it. I know you're brilliant people, you have photographic memory. Doctors are supposed to be having a photographic memory, but then sometimes, you tend to feel lethargic when lots of data is being spoken. So if you're going to do this activity with me, I'm very, very sure that your ability to retain this will be relatively better. So I'm first going to talk about the opening pressure, then is the cells in the cerebrospinal fluid. Well, when it comes to sugar, the normal sugar values are 2/3 of the blood sugar. Then I'm going to talk about the protein and even the gross physical appearance of the CSF, like it could be turbid or it could be bloody CSF. So we definitely can have interpretations. In case we are talking about normal pressure, lots of time instead of saying 10 to 20, they might actually use the units as 50 to 180 millimeters of water. Do we have cells in the CSF? Yes, 0 to 4 lymphocytes. L stands for lymphocytes. The sugar, as I've highlighted, is 2/3 of the blood sugar. In acute bacterial meningitis, CSF sugar can even be 0. We call the term hypoglycorrhea. The proteins are going to be in a range of 15 to 45 milligram percent, and the gross appearance is going to be crystal clear. This is normal data. Now, if a patient is suffering from acute bacterial meningitis, there's definitely going to be irritation of the choroid plexus, which might contribute to more production of CSF, so the opening pressure is going to be increased. You will notice that there would be a turbid CSF, and under a microscope, you may be able to see more than 1000 to 10,000 neutrophils per cubic millimeter, sometimes even higher. It might be frank pus. The sugar values will definitely be low. The protein values will definitely spike. And the physical appearance is that of a turbid CSF, so it's relatively easy. You can send the sample for gram staining as well and a CSF culture. Lots of time in Indian exams, they love to ask about tubercular meningitis. The picture would be identical in a sense that pressure would still be increased because choroid plexus irritation would cause more production of CSF, but the cell picture in this case will mainly be lymphocytes. Because it's a chronic inflammation, most of the time you will be noticing something in the range of 100 to 1000. L stands for lymphocytes per cubic millimeter. The CSF sugar will always be low but will never ever be 0. As I highlighted, CSF sugar can be 0 in acute bacterial meningitis, unmeasurable. When you check up the proteins are going to be grossly elevated. In fact, if you take the CSF sample of a person of tubercular meningitis in a test tube, you let it stand for a while, you will notice that the proteins will begin to clot like a basketball net. You can see in this case, I've shown the proteins forming a clot or a plug inside the test tube, which is hanging in the test tube upside down like a basketball net. And the technical term that they use for this is called as cobweb coagulum. They love to actually ask about this cobweb coagulum, and micropeople are very fond of cobweb coagulum. Why? Because the bacteria will get trapped inside this, and once the bacteria get trapped inside this cobweb coagulum, in those circumstances, well, you can extract this, and subsequently you can use this cobweb coagulum per se for Zn staining, LJ culture media plating, and even for performing CB-NAT investigation. The color of the CSF in tubercular meningitis would be slightly towards yellow, but do not say the word yellow. Your answer would be straw colored, because yellow would be xanthochromic, which will come up in subrecurrent hemorrhage. I have spoken about xanthochromic CSF in a case of subrecurrent hemorrhage, though I'll mention it once again also. You see, the point of mine is, if a person is having subrecurrent hemorrhage, even then, because it's after all brain hemorrhage, the pressure will be increased, but it's going to be predominantly red blood cells seen in the field, large number of RBCs which are going to be seen. The sugar and the protein can be normal or can be increased. Why increase? Because I said, you see, blood contains sugar, blood contains protein, so it's going to spike up the values artificially, and the appearance of the CSF will be bloody for the initial few days. But if you are going to do a lumbar puncture in a case of subrectal hemorrhage, let me say after 48 hours, then the RBCs are going to burst, and therefore there is going to be bilirubin that is going to be produced subsequently. So that yellowish CSF, which is having bilirubin present, is called as xanthochromic CSF. Xanthochromic CSF basically highlights the fact that now there has been a hemolysis occurring in the CSF, because obviously RBCs can't survive in CSF per se. You will notice the fact that in lot of questions you would definitely love to incorporate, and they have done this multiple times, aspects related to viral meningitis, which can be caused by enterovirus. In viral meningitis, the main cell that's going to fight the battle is going to be lymphocytes again. So the pressure is going to go up. The cells which are going to be present here, the numbers, don't focus on numbers, just focus on the fact it's going to be lymphocyte, but the sugar is going to be perfectly normal. So you definitely can differentiate. And moreover, guys, in tubercular meningitis, it's a long history over weeks. And in viral meningitis, it's going to be short history of few days. And apart from this, yeah, the protein values will increase. and the color of this can either be normal or can be turbid. So I want you to practice this table with me. In case you have not, just rewind the lecture and go through this table by yourself so that you can see very clear patterns emerging. The pattern that I'm talking about now, all eyes on the board at the moment, stop noting. The pattern that I want you to notice is that when cells are increasing, see the pattern originating, when the cells are increasing, the proteins are also increasing. I'll mark it again before you. You can see whenever in this table, whenever cells are increasing, proteins are also increasing. This is what we always see. But now I'm going to teach you a condition which is called as Guillain-Barré syndrome, which is an autoimmune condition. In Guillain-Barré syndrome, you will notice pressure is normal, cells is normal, sugar is normal, everything is normal. Even the gross appearance is normal, but the proteins are grossly elevated. Why? Because it is an autoimmune condition. That is why the proteins will spike. The technical term that we use for this and has been discussed in the lecture of Guillain-Barré syndrome is called as albuminocytological dissociation. Though albuminocytological dissociation has also been taught to you for CIDP, chronic inflammatory demyelinating polyneuropathy, albuminocytological dissociation has also been taught to you for Freund syndrome. My point is that you can now see the pattern breaking in a sense that earlier I was saying when cells are rising, proteins are rising, now cells are normal. Still the proteins are rising. So the technical term I want you guys to remember is AC dissociation, that is albuminocytological dissociation. Apart from this, I can also add the fact that if it's going to be a case of CNS leukemia, like lots of time there's a possibility that acute lymphoblastic leukemia will migrate to the CSF. We can have CNS leukemia presentation. Then the leukemia cells will definitely be evaluated on CSF cytology. Under a microscope, you would be able to see abnormal cells, that's blasts, and because they consume sugar, so sugar can be low even in cases of CNS leukemia. And another minor point that I want to say is CSF sugar can be low even in cryptococcal fungal meningitis. The finding of fungal meningitis can be almost same as that of viral meningitis. I repeat that again, the findings of fungal meningitis can almost be same as that of viral meningitis. Maybe the cell count would be lesser. Like instead of, I would say 500 cells, they might be like 25, 30, something like that cells. But the sugar values can be relatively lower in cryptococcal meningitis, because I get a lot of these messages saying, sir, in fungal meningitis, cryptococcus, what happens? It's gonna be same finding as virus. The only thing is that sugar values are notoriously normal. The point is sugar values are normal in viral meningitis, and in cryptococcal fungal meningitis, the values can definitely be lesser. In fact, I can just put it on record here, but because of lack of space, it will make it untidy. I'm just saying it at the moment. I repeat the statement: cryptococcal meningitis findings could be same as that of fungal. Cryptococcus is fungal meningitis. The findings can be same as that of viral, but the point is the values of sugar can be lesser in cryptococcal meningitis. For tubercular meningitis, guys, there is going to be lots of data given to you. Like he might describe a malnourished child who's having PEM grade 4. Then he's going to say that this child from rural India, the BCG scar is absent. Now you can understand, if a child has not been vaccinated for BCG, he'll obviously be vulnerable for CNS tuberculosis. Moreover, the aunt of this child or chacha of this child or somebody in the family had pulmonary tuberculosis and was taking treatment from a DOT center, so contact with a case of Cox. So the vulnerability of this child will definitely ensure that the incidence goes towards tubercular meningitis. And in fact, because tubercular meningitis can be frequently asked to you, let's just put in the data in the right perspective for this topic as well. In tubercular meningitis, when you will integrate this with pathology, you need to remember regarding rich focus. When we talk about the history per se, from the history perspective, I want you to remember that it would be a long-standing history of illness for a few weeks. What is the problem? The child is becoming irritable. He is not eating food. The mother is worried that he keeps on sleeping for most part of the day. Whenever he wakes up, he does not eat. And child cannot say headache, so he might bang his head against the wall. The child is mostly drowsy, irritable. He was a very playful, cute, cuddly child, but now the behavior of the child has changed and the mother is noticing it. In fact, every mother, educated or uneducated, definitely make out her child is sick. Gradually, she is noticing that the child is not able to even recognize her. Altered sensorium and the oral intake has practically become zero. At this point of time, there might even be episodes of focal seizures because of which they showed some local RMP doctor, no improvement. Then she is noticing that the child is not even moving his legs. There might be monoplegia because in tubercular meningitis, there is end arteritis also. the blood supply of the cortex can be hampered. So you could be having mini strokes. There could be multiple mini strokes happening. Why? Because I said the lesion could be end arteritis, damage to the blood vessels of the brain by the TB bacilli. There could be monoplegia, there could be paraplegia, depending on whichever part is damaged. And yes, the findings of meningeal irritation, that is nuchal rigidity, will also definitely come into being. Now, I can explain this by drawing the ventricular system of the brain. You can take this to be the representation of the lateral ventricle, which is connected to the third ventricle through foramina Monro. The third ventricle is connected to the fourth one via aqueduct of Sylvius. Then we have the lateral foramina, Luschka, medial ones, Magendie. You all know about the basic anatomy. And this that I've shown are the basal cisterns. The CSF is going to be routed like this and is going to be navigating via the basal cisterns, then into the subarachnoid space, and then is going to be gradually reabsorbed. What I'm trying to say is that in tubercular meningitis, the pus that is produced is too thick and it accumulates in the basal cisterns, because of which it will obstruct the flow of CSF, resulting in a dilatation of the entire ventricular system. So this child will definitely end up with hydrocephalus manifestations as well. Let's look at what the examiner will say. Because of the hydrocephalus, he might say that on physical examination, the doctor could elicit a Massivan sign / a crackpot sign in this patient, right? That definitely tells you that there can be sutural diastasis occurring in the patient. You see, when hydrocephalus will occur, the sutures will separate. So sutural diastasis can definitely be felt. The superficial veins of the scalp will be very, very prominent. There might be even sun-setting sign because of the hydrocephalus. And the type of hydrocephalus that I've shown here before you is called as non-obstructive, because as such you can see that there is no obstruction of the foramina Monro or of aqueduct Sylvius or of Luschka or Magendie. So he can either use the word non-obstructive or he can use the word communicating. Hydrocephalus developing in this patient. Why? Because there's going to be pus that's going to be blocking the basal cisterns, and therefore the radiology chap will say basal exudates. The kind of hints that are provided earlier, I talked about, a malnourished child, absent BCG vaccination. Those are all points that could be given. But apart from these, lots of other points in history could be given, which could definitely sensitize you to the diagnosis of tubercular meningitis, even if the CSF picture is somewhat dicey and is looking like that of viral, but viral should be having a short history. The investigation choice obviously would be a PCR/CBNAR. So I would definitely like to do a PCR of the cerebrospinal fluid for Mycobacterium tuberculosis. That will definitely confirm the diagnosis of this particular patient, and then we will start the patient on treatment. For treatment, it is antitubercular treatment for 6 months. Yes, the same duration as for pulmonary tuberculosis, but this would be supplemented with steroids. When I say steroids, the query of most doctors is, sir, steroids in infection. Steroids are not given in infection. Yes, but here we are giving steroids. Why? Because I want to reduce the cerebritis component. I want to reduce the cerebral edema component. Most importantly, steroids will also enhance the penetration of antitubercular drugs into the meningeal space. Most antitubercular drugs are not able to reach the meninges. That's where the bacteria are sitting. You see, you need a targeted intervention. If terrorists are sitting at some area, you need to send in a SWAT team. You need to send the national security guards to destroy them. Similarly, the bacteria are hiding in the meninges. So you send in a specialized team, hit them hard, and therefore you need supplementary support with the help of steroids. The advantage of steroids is two. Reduces the cerebral edema component, it enhances the penetration of antibiotics into the meningeal space, and therefore the patient will definitely improve. In contrast, when it comes to acute bacterial meningitis, the treatment part has already been discussed in meningitis part 1, but I just want to remind you the fact that in acute bacterial meningitis in pediatric age group, again they might mention steroids. In fact, the pediatrician might say give the dose of steroids before giving antibiotic, because suppose the antibiotic is to be given at 9 a.m. in the morning, the nurse might give a steroid injection at 8 a.m. Why? Because again it will enhance the penetration of antibiotics into the meningeal space. In acute bacterial meningitis, if he talks about a child less than 3 months of age, then we are obviously thinking in terms of Listeria monocytogenes. So the antibiotic that would be used in this case would be ampicillin, because that is how you can kill Listeria monocytogenes, but they can be group B streptococcus also. What will you give to kill group B streptococcus? You would give cefotaxime. Don't answer ceftriaxone. It's not used in especially small babies because of risk of jaundice. I have already told you that if it's going to be a child older than 3 months and then adult up to 55 years of age, the standard treatment that we will use is ceftriaxone. If ceftriaxone is not given in the options, you can definitely answer cefixime in its place, and don't forget to add vancomycin in the answer as well. So it's a combo that would be used. However, if the age of the patient is more than 55 years of age, then again the situation will change in a sense that Listeria monocytogenes prevalence will again increase. So ampicillin comes in the picture. Along with this, the standard treatment of ceftriaxone will continue. Instead of ceftriaxone, I'm writing cefixime with vancomycin. Also, there could be scenarios where pseudomonas can come in, especially if we are talking about some intervention done in the patient, like maybe intrathecal methotrexate was given by JR1, and the child is having then a hospital-based infection because hygiene was not maintained. So in those circumstances, I will definitely be more careful. I mean, listeria is obviously gonna be notorious, but I can be having the requirement of using ceftazidime, that's a third generation cephalosporin, especially for pseudomonas, and because lots of time nowadays it might be drug resistant, so I will be forced to add meropenem as well. The main part I want you to remember here is the second one. That's what they usually gonna ask, but I just wanted you to be sensitized to Listeria monocytogenes as well. I mean, our examiners love to ask about Listeria monocytogenes for the age groups that I've highlighted, so then it would be answered as ampicillin. Towards the end of this picture, I would like to also mention regarding a term written in the textbook by the name of chronic meningitis. I mean, that looks very surprising because the impression in our mind is that meningitis is always going to be in acute. But yeah, I mean, when it comes to tubercular etiology, or maybe when it comes to brain-eating amoeba that I was talking about, Naegleria fowleri or acanth amoeba, there's a possibility that manifestation might develop after a few weeks. Like the guy went to his village, he did swimming in stagnant water, but the symptoms of meningitis might develop after a couple of weeks as well. So the message is, I mean, when would you see chronic meningitis? When the neurological symptoms in a person are gonna be rather long standing. I'm not saying that it's only about the fact that the incubation period is longer. It's not only about that the incubation period is longer, even the manifestations would be longer standing, like for example in tubercular meningitis or even in malignancy. In chronic meningitis, overall the WBC count in the blood will definitely be increased, apart from the increase that will occur in the cerebrospinal fluid. And there are various etiologies for it that I have highlighted, but I'll just summarize them. It could be standard infections, which could be in the range of tubercular meningitis. It could be CNS leukemia. He could say leptomeningeal metastasis that is seen with carcinoma breast. Even autoimmunity, like one of the diseases, especially from autoimmune perspective, that I want to say can contribute to chronic meningitis is Behçet's disease. That is oro-oculogenital syndrome that we have discussed. Then it could be drugs like, I'll say a very surprising thing, ibuprofen. That's a very old MCQ, and it was regarding which painkiller can contribute to chronic meningitis. It is actually ibuprofen, after which a person can surprisingly have a nuchal rigidity. So drugs and chemicals definitely would play a role as well. I would like to finish this topic by lastly mentioning regarding the term CSF eosinophilia. Now we traditionally read about eosinophilia with respect to blood circulation, but in the CSF, well, one, I want you to remember a fungal infection coming up here, that is Coxoides immitus. And the second one is a rat lungworm, though I would say that I have discussed about hantavirus, which can cause hepatopulmonary syndrome also. Hantavirus is transmitted by pet rats per se. So two diseases which can be spread by rats apart from, rat bite fever. One, they love to ask regarding hanta fever as well, which should be known to you. And this is just an accessory detail that you can remember towards the end of this discussion. The main crux of this discussion was to sensitize you to this table that I've highlighted for various situations that you should be able to analyze. The questions on meningitis topic are gonna be long, but they're very easy. If you just get the cell aspects right, the sugar values right, you would be bang in place to actually solve these questions. And I can just say one more hack. It's a small one, but then try to listen to this also. You would have noticed the fact that when you look at the chloride values in the blood and you compare this with the chloride values in the CSF, there is a stark contrast. Why the stark contrast? Because how much is the chloride present in the blood or plasma of yours and mine? Then chloride values are something in the range of 96 to 106 millicoulomb, but in the CSF the chloride values are 130. You see, normally everything is less in CSF. No, if you look at the CSF sugar versus that in the blood, CSF sugar is less. If you look at CSF protein versus that in the blood, it is less. Cells, cells are going to be larger number of cells. There are RBCs, WBCs, platelets in the blood. There's only 0 to 4 lymphocytes in the CSF. Everything is less in the CSF on a magnitude as compared to chloride per se. The chloride values are increased because of active transport. Now I want to tell you that if there's going to be a bacterial etiology of meningitis, mark my words there. If there is not a viral, I'm saying bacterial etiology of meningitis, then this active transport is usually hampered and the CSF chloride values can be lesser. So the message is that suppose in a multiple choice question, you are still stuck between whether it is tubercular meningitis or viral meningitis. Though I said lots of points regarding that, especially from viral perspective, I said there could be frank psychosis, it would be short history 1 or 2 days. But the point is, if you're still stuck, then if CSF chloride, the word is if CSF chloride is given, forget about even lesser. If CSF chloride is given in the question, you should give benefit of doubt to bacterial infection. It is CSF chloride values are not affected in viral. They are mainly affected in bacterial etiology. Don't get into more or less. I said it will be lesser because the active transport would be hampered. But the point is, if CSF chloride is given, you have to give benefit of doubt to bacterial etiology. So you will get a lot of questions on the topic of meningitis, which will be relatively longer. They really are trying to test your patience, and these questions get on your nerves, because they're gonna mention lots of data present here. They might mention information of cells versus sugar versus protein. So when you read it, it's gonna take a little more time. That's where the patience part has to come, and you just need to be focusing on certain issues that I've highlighted. So if you can just get this table right, either take a snapshot or if you've noted it with me, great. I mean, I'm very sure that if you are gonna do this hard work of noting it down, your strike rate will definitely improve. I shall now be discussing regarding clinical features that would be present in a case of acute bacterial meningitis, and you obviously need to look for evidence of meningeal irritation in the patient. In fact, two of the very classical signs of meningeal irritation that you're able to elicit is one, the Kernick sign, in which you will be doing an extension of the leg of this patient. You can see the position of the leg per se. One hand is just below the ankle, the other hand is on the knee, and when you elevate the leg, it is going to contribute to extreme amount of pain, especially in the back and with respect to stretching of the hamstrings. In contrast, when it comes to Brudzinski sign in a patient, when you are going to flex the neck of this guy, there's going to be an involuntary flexion that's going to happen, especially at the knee and slightly at the hip joint as well. So meningeal irritation is definitely to be documented. Now, the triad of acute bacterial meningitis may be present only in about 40% of the cases, but still it's worth its money or worth its weight in the MCQ. That would be fever, headache, and nuchal rigidity. I want to highlight the fact that without fever present on only nuchal rigidity, let me say in a multiple choice question, only point number 2 and 3 are given. Headache of sudden onset with nuchal rigidity, I will think in terms of subarachnoid hemorrhage as well, and I've already sensitized you it for the same. Along with this, evidence of raised ICP would be present with respect to projectile vomiting developing in a patient. You see, projectile vomiting basically means that there's going to be vomiting without any warning. There's going to be no nausea. It's not about how far the vomiters would go. It is rather that there is no nausea and it occurs without warning. Then the pupils of this patient, when you will examine, because the pressure in the brain is rising, so the pupils might be bilaterally poorly reacting to light. You might actually notice the patient is lying with his eyes closed. But when you try to open the eyes, one, you will notice photophobia, and along with that, the pupils are uniformly dilated and they exhibit a sluggish or they exhibit / a poor reaction to light. The next point which I want you to remember is more of a symptom which I've already said, right? I said the patient might be lying with his eyes closed. When you ask him to open his eyes, he may not open his eyes. Or even if he will try to open his eyes, you will notice that in the bright lights of the casualty, the person might be opening his eyes partially. That is a photophobia component which will be troubling the patient. In case the patient reaches late, then there can even be posturing. Now that is obviously a bad finding, and you would have noticed lots of time tubercular meningitis patients, they usually might present very late with posturing. So initially you would be having decorticate posturing, and in the later part of the illness there might be decerebrate posturing. So the sequence has to be remembered: decorticate followed by decerebrate posturing. In decorticate there would be flexion, and decerebrate alphabet E is coming again and again, so there would be an extension developing in the body. Since the pressure in the brain is rising, there will definitely be pressure on the cranial nerves as well. The cranial nerve that has the longest route, which is subarachnoid, that is, it's traveling through the CSF, and when the pressure in the brain will rise, this nerve will be the first one to be affected. Sixth nerve palsy is technically called as false localizing sign. Why do they call it false localizing sign? Is because the disease is per se not in the sixth nerve. It is just accidentally that the nerve is getting involved in the patient. So the message is sixth nerve palsy is a false localizing sign. It just helps you know, or it just sensitizes you to the fact that the person that we are dealing with in acute bacterial meningitis, he is basically deteriorating. And well, from the management perspective, though I'll speak about this in the next slide, I want to highlight the fact that the primary thing that must be done in all cases of acute bacterial meningitis is that you should draw blood sample culture, because the infection went into the brain ultimately by the blood. So the first investigation is not a lumbar puncture. Actually, the first investigation to be done is a blood culture, followed by administration of empirical antibiotics. And now what I'm saying is itself an MCQ, that antibiotics should be given in a suspected case of acute bacterial meningitis within how much time? The answer should be given as within 60 minutes of admission. When I describe it, query from young doctors is, sir, will it not affect the CSF picture? You are giving antibiotics even without doing a lumbar puncture. Please remember the fact that this has been validated by various clinical studies, that if you give antibiotics early, you will be able to reduce the mortality by substantial percentage points. There's a substantial significant reduction in the mortality. At the same time, the changes in the CSF are not substantial. I mean, it's not that the neutrophils from the CSF is going to disappear. The gram stain might still be positive. The culture might even still be positive even if you are given a single dose of antibiotic, because even antibiotics will require some time to develop substantial concentration in the meninges and start killing the bacteria. So empirical antibiotic therapy is of great importance for management of these patients. And I would like to just summarize these facts once again, but in a slightly different fashion. You see, if he gives you a question from a clinical domain of a patient having headache, fever, and I'm writing plus minus nuchal rigidity, because lots of time, if it's a child, right, he might be scared of you and he might involuntarily stiffen his neck muscles. So you might be getting a false impression that the person is having a nuchal rigidity, whereas it may not be present. Or if a person comes relatively early, even then nuchal rigidity may not be present. But let us say with a person having combination of the above findings, you are noticing that he is not oriented in time, space and person. There is a altered sensorium. Then what are the differentials that should be definitely kept in mind? One of the important differentials to be kept in mind is acute disseminated encephalomyelitis. And most of the time, if the question is given as acute disseminated encephalomyelitis, then it would be seen post-vaccine. Mostly the older generation of vaccine for rabies, like the mouse brain derived vaccine, that is what can contribute to ADEM. Then I should definitely keep into consideration meningoencephalitis. So do remember that in this slide, I'm not focusing only on the diagnosis of meningitis. I'm saying additional disorders should definitely be kept in mind, including possibility of metabolic encephalopathy, because if a person is having fulminant hepatic failure, he is having acute kidney injury resulting in uremic encephalopathy, again the altered sensorium component would come up. Then you should also keep your mind open to the fact that person could be having intracranial space occupying lesion present, because even when the pressure in the brain will rise, again altered sensorium can occur. On the other hand, if the altered sensorium is a no in the person, then the first differential that should be kept in mind is definitely meningitis. When I say this, the query from your side would be, sir, I've seen patients of meningitis and altered sensorium. I agree. If the patient will have raised ICP, he will go into altered sensorium. Point is, initial presentation of meningitis, you may not be having altered sensorium. In fact, the focus is on early identification of the disease. So what are you going to get in a patient of meningitis in the early part of the illness? You may be having papilledema on a fundus examination. There might be a focal neurological deficit present. There might be a history of sinusitis and a course of antibiotics that has been taken in the previous 1 week. Or there could be a history of head trauma occurring in a patient, because head trauma per se, like there's a CSF rhinorrhea or CSF otorrhea, then again the chances of meningitis via the contact of the CSF with the peripheral environment can increase. This table is just to sensitize you to the fact that do not comment on the diagnosis of meningitis right away. Keep a watch for the other differentials also to be present. And obviously the workup is there and investigations there to differentiate these conditions. So let us now discuss what are the investigations which are going to be done. Though I've highlighted this already, I want to emphasize that the first investigation in a suspected case of bacterial meningitis is not going to be lumbar puncture. It is rather obtaining blood culture. Then administer empirical antibiotics within 60 minutes of arrival to the hospital. Perform a non-contrast CT head to rule out evidence of raised intracranial pressure. Perform a lumbar puncture in the patient then, and the technical lumbar puncture and aspects related to lumbar puncture are discussed in meningitis part 2 lecture. But at this juncture, I want to highlight that this is not the first test to be done. This is the subsequent test to be done. First is blood culture. And now let us see what will be the CSF findings in the person. Obviously, gram staining will be done. Culture will be done. But if you read the report saying more than 1000 neutrophils per cubic millimeter, and there is a turbid CSF. In fact, when I started this discussion, the very first slide that I showed you was having a turbid CSF, and you can very well notice the Diplococcus present here, right? You can make up two dots present simultaneously. That is going to be pneumococcus, which is one of the leading causes of development of bacterial meningitis in a patient. So what I have explained to you is that if you are going to be having predominantly lymphocytes, now listen to my next words very carefully. If you're going to be having CSF lymphocytosis and the sugar in the CSF is relatively low and the history is long, it would be tubercle etiology. If it's going to be CSF lymphocytosis with history of 1 day and sugar in the CSF is normal, it would be viral etiology. I emphasize this again, lots of time in the exam they will give you lymphocytosis in the CSF. First differential diagnosis is obviously tubercular meningitis, but will have a long history of weeks. And if it's gonna be few days, then you will have to think in terms of viral etiology. The CSF sugar of the patient will be reduced. Instead of writing the word low CSF sugar, one of my students actually asked me after the exam, sir, there was a term written hypoglycorrhea. He said, sir, what does it mean? It basically means low CSF sugar. Now, obviously, the examiner can either write the word hypoglycorrhea or he can write this ratio, that is CSF glucose divided by serum glucose values. And if you see this value to be less than 0.4, it goes in favor of bacterial meningitis. Because there are going to be antibodies produced against the infection, the protein values will obviously be spiking in the patient. Once I get the findings that I have highlighted, how much amount of CSF is required? Well, usually less than 20 ml. Though if they ask you in the exam that how much ml of CSF can be removed safely, then approximately 20 to 30 ml CSF can be removed safely. Now, why is this a range? Everything in medicine is a range. Well, I can explain it in a simpler fashion. There is a medical condition called as normal pressure hydrocephalus. In normal pressure hydrocephalus, there are gait abnormalities in a patient. There's a triad that I've discussed subsequently, dementia, ataxia, incontinence. So because the gait abnormalities in normal pressure hydrocephalus, we can remove up to 30 ml of CSF in these patients to get a gait improvement. And what I just explained to you, don't need to note it down. I'll just mention this casually. You have all read Miller-Fisher syndrome. That's important. I just taught you a Fisher's test. Fisher's test is done in normal pressure hydrocephalus where you remove CSF from the patient, and this causes a improvement in the gait of the patient because most of these patients will be having tendency of recurrent falls. I want to say that normal pressure hydrocephalus is itself an enigma because on one hand I'm saying hydrocephalus, other I'm saying normal pressure. Well, this condition is characterized by more CSF production at night, which causes expansion of the ventricular system and causes cortical atrophy, so dementia. There could be development of pressure on the frontal lobe, so urinary incontinence. And because of gravity, because the pressure will be on the cerebellum, that is why the ataxia. So normal pressure hydrocephalus has a triad of dementia, ataxia, incontinence. The gait abnormality can be improved by removal of CSF of these patients. So there's a range given in the textbook. So I was just trying to give you a justification for the same. And I would like to finish this meningitis part 1 by lastly mentioning regarding the antibiotic that would be used for management of patients of acute bacterial meningitis in patients age group 3 months or lesser to 55 years. Please remember that if a person's age is specifically given in the question to be neonate or 1 month or 2 months, you have to keep into consideration Listeria monocytogenes. But as he starts growing toward infantile age group right up to 55 years of age, then the incidence of Listeria monocytogenes will become lesser. So then you can definitely use ceftriaxone. Remember in the starting only I told you Listeria monocytogenes does not respond per se to treatment with ceftriaxone. We have to give ampicillin for the patient, but in this case because Listeria is out of the picture, so it is ceftriaxone with vancomycin. Yeah, 2 antibiotics being given, so don't be surprised at that. And this is the commonest antibiotic regimen that will be useful for management of ABM per se. Acute bacterial meningitis, guys, is a piece of cake. The only thing is in the question he may not mention regarding a characteristic nuchal rigidity or signs of meningeal irritation, but then you will be able to pick it up because the patient is not well, he's running fever, he's having headache, he's having vomiting, 6 nerve palsy, and the CSF picture will clinch the diagnosis for you. In meningitis part 2, I have compared the various types of etiologies. This was primarily to focus on 2 main domains, that is organism specific approach should be very, very clear. And whenever you read terms like hypoglycorrhea, CSF sugar being 0, is a feature of acute bacterial meningitis. Lymphocytosis in CSF with a longer history is to be thought in terms of TB, and a shorter history is to be considered with respect to viral etiology in a patient. So these are the details that I would like you to remember for this topic. Thank you so much for hearing me out.